Well, I'm from Emden. Greetings from Northwest Germany, and very special times, yes. And COVID-19 rises in our ward just in the moment. I have just in the moment 2 patients, and after my lecture, I will try to find out if I have to treat them with CytoSorb. So we begin with the first slide, please. And one of the remaining questions in this therapy is which patient has to be treated and when do we start the therapy? And from the company there is a card which shows at the left the stable patient. He turns to being unstable, has a shock and refractory shock. So what is a refractory shock? And that's still the question. So we ask when to start and whom to treat. Next, please. If we are looking on critical patients, critically ill patients, we look at first at the SOFA score or other scores like Apache. So the SOFA score remains to detect the organ failure. There's a study from Belgian colleagues in 2001, which shows that the delta, the uprising, increasing or decreasing from the beginning SOFA score is important for survival. And next, please. So a change in SOFA score is the indicator for conventional therapy failure, but that's a little bit difficult because the SOFA score delta in between 24 or 48 hours. So it is very late to decide therapy, yes or no. Next, please. So we tried to develop data matrix from the early phase of septic shock, 6 hours, a dynamic data matrix with volume and catecholamine requirements, lactate clearance, and application of adjuvant methods to detect refractory shock. The hypothesis is based on this dynamic changing in the first 6 hours in the early septic shock, a score can be generated that correlates with mortality, and we can define a score range from patients who probably benefit from early treatment. We did this with 4 centers, 2 from Germany with Hamburg University, Austria, in Baden, and Switzerland, in Münsterlingen, and our. Next, please. So we retrospectively took data from over 500 patients, of whom nearly 200 were treated with CytoSorb and over 300 were treated conventionally without CytoSorb. And we analyzed the catecholamine demand, blood lactate, as told before, volume demand in a 6 hours window. Next, please. Next, please. This score is generated with thresholds from lactate over 2 millimole per liter, lactate change in between 6 hours, the noradrenaline demand from above 0.1, the change in between this first 6 hours, uprising or increasing or decreasing, if we need a second catecholamine or not, if we use hydrocortisone or not, and what bolus volume we did need. Next, please. So next, the question remains, what is septic shock and what is refractory shock? And if we define lactate, first lactate and first catecholamine and first volume with a stable patient, that means septic shock, but stable, not uprising, not refractory, that is mapped in this dynamic approach with 5 points. Next, please. So we looked in the entire patient group above 500 patients if there is a different risk with defined scores. And we had, one moment, so we had the patients below 6 points with normal, I mean normal septic shock, the mid-risk patients with 6 to 8 points, and the high-risk patients with above 8 points. So it is, we looked in the first 7 days, because this is after initiating therapy, or after taking the diagnosis of septic shock, the first 6 hours, and after that, the 7 days that represents after treatment with CytoSorb. In example, the first 3 days therapy, and after that, in the first week, the best look over the improvement from this. So we had significant advantages in between the groups. Next, please. And if we look about to the whole time of treatment, over 8 weeks, it's still significant between the groups, from below 6 points to greater 8, and 6 to 8 greater 8. Both is significant in the entire ECSISS group. Next, please. Then we had a look to the CytoSorb group. These patients who had been treated with CytoSorb, you remember, nearly 200. So is there the same different risk between groups? And we looked about below 6, mid-risk 6 to 8, and high risk greater 8. And in the first 2 ranges, you did not see anything, but in below 6 to greater 8, it's significant in the first 7 days. That is the first week after beginning treatment from CytoSorb. And if we look at the next slide, above 8 weeks, looking on the whole time, you see something important. On the left side, you see the turnover from the low-risk group below 6 points. They turned over to have the worst outcome. And after 8 weeks, we see a significant advantage from the mid-risk to the high-risk group. So to explain this, you have to look on the number of patients. And if you remember the first or second slide with the SOFA risk, you remember perhaps there's one group from over 11 SOFA score in decreasing SOFA score, and the risk for mortality rised up. So that remains to the low patients, 5 patients in this group. And in our patients, it's the same. In the group below 6 points, there are only 17 patients out of 200. And that is the explaining for turnover from this. So the next slide, please. We had another look, not only on the score risks, then the other question is, is there any influence from the delay from beginning the therapy? We always say below 24 hours, beginning early is advantage. And if you look at in the first week, you don't see any difference. But if you are looking on the whole patients, next slide. In the end, you see that the early beginning in the first 12 hours is an advantage to 12 to 24, and even the mid range from in between 24 hours to over 24 hours in the end at all patients. Next slide, please. So in the end, there's one question remaining. Are there any advantages in subgroups? We have now defined with our score different groups from relative risk, different mortality risk. And now there is the second question: is there in the delay, is that an advantage? And in the end, we want to know if the combination of this detects patients in subgroups who have an advantage, and can we define patients who profit from early therapy and the score, perhaps. So we have several subgroups analyzed, and as one example, we analyze the CytoSorb-treated patients with the group of patients who had conventional therapy but had an acute kidney injury with the need for CRRT. And if we look at these patients with the different scores in the first 12 hours treated with CytoSorb, we see a significant advantage in the patients who had the high-risk score group. That means the combination from an early beginning in the first 12 hours and the high-scored patients has a severe advantage for survival in our patients. Next, please. So in summary, the dynamics represented in this score correlates with survival and helps to define the right patient in the entire group, in the CytoSorb group, shown in both. The early treatment is significantly advantageous, shown in the whole patients at the end. And there are exactly certain subgroups that benefit from an early treatment. These subgroups, that's for the future, for further studies, these subgroups should be further investigated in perhaps this group with CRT. Pneumonic patients showed benefit with early beginning, and the high-risk abdominal septic patients showed benefit as an example. Next, please. Beside our data, as I told, the ECSISS data depends on data from Tobias Hübner, Franz Schwammeis, and Dominik Jarzak from the ECSISS group. Next, please. And for sure, the staff, thanks a lot for the hard work. Thank you very much.